for most of our patients who got pregnant through IVF, from when your pregnancy is confirmed, and we see congratulations, you're pregnant, all through the phase of your luteal support, so when you register for antenatal and then you continue. And for those who got pregnant continuously, from when you register for your antenatal care up onto the delivery. So we have the antenatal clinic, we have the antenatal classes, like the one we're having right now. We have the postnatal clinic, the clinic after you have delivered. It's important to know that concerning the antenatal clinic visit, it is based on appointment. Most people will register for their antenatal care after the second missed period. And the first antenatal clinic visit is called the booking clinic visit. And usually after that visit, you're seen regularly 3 to 4 weeks until you get to 28 weeks, when you're seen every 2 weeks, and then from 36 weeks until delivery, you're seen every week. Now, when to register for your antenatal? Most people will want to wait. Most people will register after their first missed period. All right? Some will prefer to wait until after their first 3 months, after the first trimester. Now others would want to come early, maybe because of a previous miscarriage. All right? For a lot of our patients, probably maybe most of you that are here who got pregnant through IVF, you actually register for antenatal care after you have completed your luteal support, and then you've had your cervical setting done, and then you go on to register for your antenatal. But your antenatal actually starts from the day you were confirmed pregnant, because your luteal support program is also a big part of your antenatal, because you are seen every 2 weeks when you come in for scan. All right, so part of that luteal support program takes care of your first 3 months or 6 or 7 weeks of pregnancy until your 3 months. And thereafter, if you decide to do your antenatal with us, then you can now register for antenatal, and then you continue with our antenatal care. But if you choose to do your program in another, do your antenatal care in another facility, then you can now go and register with them and then continue. All right? Who to see during your antenatal clinic visits? We have doctors, we have nurses. All right? For us at the Joje Center for Women's Health, your antenatal clinic, your antenatal care is taken by a combined team of doctors and nurses. All right? And we also have some other members of the team whom you may see at some other times during your antenatal or delivery period. For example, the neonatologist, the anesthesiologist. These are all members of the team, but you don't get to see them until it is necessary. But we all work as a team. Okay? So the first antenatal clinic visit is very important. Why do I say so? Because that is your first visit. But most of us here probably do not have a first antenatal clinic visit the way it is structured. Why? Because you came to get pregnant. You went through IVF, you got pregnant, and then we continued with your care. So a lot of what I'll be saying that takes place in the first antenatal clinic visit, usually you didn't have it because that was done when you came to register with us to get pregnant. So what is done normally when you come for your first antenatal clinic is what we call the booking visit, is that you will have a consultation and have a medical documentation done. All right. Of course, before you do that, you will have had your vital signs taken. We are going to go into all of these because as simple as vital signs is very important. That is why any woman who comes for antenatal and you've not done vital signs, you didn't come for antenatal. You came for something else. All right? Vital signs and those things they measure when you come for your vital signs are very, very important. So you book to see the doctor. All right? And that's why every clinic visit is a scheduled visit. You don't just walk in and say, okay, I've come. No. If you come in like that, you may be seen, but you will be delayed. So any visit you're making, you must call the hospital and have a visit scheduled for you. And then once you come in, you take a rest for about 15 minutes, and then you are ushered in to have your vital signs done. And after that, you go ahead and see your doctor, who will do a medical documentation, examine you, and then you go in for your laboratory test, and then you're given your medications. That's about how the process goes when you come in, right from the first visit that you make. So what are the vital signs that are taken during your visit? The first one, you have the blood pressure next. And these vital signs must be taken in each of your visits. You have your blood pressure, the pulse rate, temperature, respiration, your respiratory rate, and then your oxygen saturation. These are all the things that are measured. The other two that are checked. Next slide. You have your weight, your height. That gives you your BMI, your body mass index, and then urinalysis. Check your urine. These are all the vital signs that are checked, and they're all very important. Starting with the blood pressure. Next slide. How many of you have come for antenatal and then you didn't do your vital signs before? Ah, seriously? You came for antenatal and then they didn't check your blood, they didn't check your vital signs. Who's your coordinator? Sister Rachel. Where is Sister Rachel? She was here before. She stepped out. So you don't do, okay, this is your second visit. Oh, okay. So technically, you've not registered for antenatal. You are doing your luteal support. But even patients that are doing luteal support, they should have their vital signs. And so that's why you are here. You are hearing it from the horse's mouth, as you say. Once you are pregnant, say congratulations, you are pregnant. Whenever you come to the hospital for checkup, you must have your vital signs done. Please, all patients, just note this. It is very important. If you come and say, I want to see MD and just say MD, hi. First of all, I ask, is she pregnant? They say yes. Has she done her vital signs? No. Go and do vital signs. Even if you say, MD, how are you? Go and do your vital signs. As long as you're in the hospital. It is very, very important. I'm saying this to say the vital signs are very important. So the first thing that you check when you're doing your vital signs is the blood pressure. Why is the blood pressure very important for us? Because it can change during pregnancy. There's what we call pregnancy-induced hypertension. Some people may not have blood pressure issues before, but once they become pregnant, then their blood pressure may go up. So we want to know what your blood pressure is, so we'll keep monitoring you each time you come for your checkups. Okay? So when you come, you rest for 15 minutes. You don't just come in and say, Founders, how are people doing? Oh yeah, yes, nurses, are they inside there? And just walking. No. When you come, settle down. Okay? Settle down. Because some of you may have been driving, thinking you are late for your appointment, you are driving like James Bond. And some of you, when you come in, just settle down first. All right? And 15 minutes after, you can go in and have your blood pressure checked. Like I said before, pregnancy-induced hypertension is one of the common causes of maternal morbidity and mortality. That is why it's very important for us to be on top of your blood pressure. All right? Next slide. So when you go in, okay, so typically they will use your left arm to measure. We use both the electronic monitor and the manual, and then they check your blood pressure. What's normal blood pressure? Less than 140/90. 140 diastolic, 90. 140 systolic, 90 diastolic. Less than that is normal. But once it begins to get to 140/90, that means your blood pressure is right. Sometimes we can also use the difference. All right, the difference between the initial systolic and the new systolic. If the systolic is more than 30, the diastolic is more than 15 in terms of the difference, then that can become significant. Some patients have blood pressure of 90/50. If it becomes 120/80, it's still perfectly normal, but for them, it has increased. So that is why it's important for us to note. And the good thing is that for most of us here, we knew you before you got pregnant. So we have your records to be able to compare what your blood pressure was pre-pregnancy and what it is now. All right? So we'll check your blood pressure, both the systolic and the diastolic. While you are pregnant, the blood pressure that we're more particular about is the diastolic. Because systolic, a lot of things can cause your systolic to high. Just stress alone, shouting. Please, pregnant women, please don't shout when you are pregnant. If anybody are near you, just say, When you shout, your blood pressure will go up. And men, I wish men were this. That's why I said men should come. Men, don't get your woman, your wife angry. Don't get them angry. Just pet them. Okay? Because the woman that is pregnant is a fourth human being. It's not, in quote, normal. Little things can just, so you understand her condition with her well. Bottom line, you must make sure that nothing exacerbates them, nothing gets them agitated. If not, their blood pressure can just go up. All right? Okay, so next slide. So after we have done that, then the next is the heartbeat. The heartbeat talks about how the heart is beating. Normal rate is between 60 to 100. Okay? If it is above 100, that means it is high. If it is below 100, below 60, that means it is low. Pregnancy on its own can cause your pulse to rise. Okay? But because during pregnancy there is an increased blood volume, so your heart is pumping more. To make sure that there's increased circulation, your baby is getting enough of nutrients and all of that oxygen. So there's usually an increased heart rate when you are pregnant. And also drugs can also increase your heart rate. One of the drugs that increases heart rate, which we give to you, and that's why you need to note it, is what? salbutamol. When you take salbutamol, your heart will just start racing initially. Don't panic, don't fear. Follow what it does, but after a while, it gets better. You can take it early at night. All right. Other things that can cause your heartbeat to increase is if you are pale, if your blood level is low. And the way you know that one particularly is because you get tired easily. You climb stairs, you are panting as if you just ran 100 meters. Any little walk from here to there, you are feeling so exhausted. Once you begin to have that feeling, then you need to check your blood level to be sure that you are not anemic. All right? And of course, if you're having a fever, all right, these are the things that can increase your heart rate. Of course, there are other things that can make your heart rate to be low. So we come in and we check your heart rate and it's below 60. It will mean that there could be a cardiac condition that will require you to be further investigated. Okay? And then respiratory rate. We also will check your respiratory rate. Your respiratory rate should be between 18 and 22. Sometimes for women who are pregnant, their respiratory rate also tends to be high also. I'm saying this so that when you go for your vital signs and they check respiratory rate and you say it's 24, don't begin to panic. Say, hey, MD said it's 18 to 22. What is happening? Calm down, relax. Nothing is happening. You are pregnant. It is possible that your respiratory rate will be high. But if it's very, very high, then it could mean that there could be a respiratory condition. Okay? You have an upper respiratory tract infection, pneumonia. All of those things can cause you to have a high respiratory rate. And of course, we also check your oxygen saturation to make sure that you're saturating well, that your blood is carrying enough oxygen. 98 to 100. Next slide. 98 to 100 is usually the value that we get. Of course, temperature is important. Next slide. Check your temperature. Temperature 37 is normal. Above 38 is significant, and that could mean that you have malaria, typhoid, or one of these common disease conditions. Okay? And then your weight. You check your weight. Weight is very important because we want to know what your starting weight is, what your weight is as you come, because we expect you to gain weight. All right? We expect you to gain weight. Absolute weight, 90 kg. Anything above 90 kg, that means that patient is obese. Yes. And then, of course, if you are less than 40, that means you are underweight. All right? That those two extremes are not good. So we expect a woman to gain about 15 kg during the course of her pregnancy. Some women gain more, some gain less, but averagely 15. So that's why we check. And then we expect that every week, 0.5 kg is what you gain. Some people lose weight during their first trimester because they are not eating, and then they start gaining that weight they've lost, and then they can exceed it afterwards in the second and third trimester. And then your height. Why is the height important? Just to be able to measure your BMI, the body mass index. All right, is a more accurate way of determining the impact of your weight, because a woman who is very tall and a woman who is not so tall, the impact of the weight is different. And so that is why a body mass index gives us a good reflection of what the impact of the weight is. And if you see the next slide, you can see what the body mass index is. Normal is 20 to 24, and then below that is low, and above that is overweight, obese, morbidly obese. All right? And then the last test that you do is urinalysis. Very important. You came to the clinic, you did your blood pressure, did your respiration, did weight, did everything, and you did not do this one. It is not complete. This is very, very important, because the parameters that are checked there it can exclude a lot of things. For example, if you do your urinalysis and there is glucose, that could mean there's a problem with your sugar, and we need to now do further tests. If you do your urinalysis and there's protein, that could mean preeclampsia, or it could mean urinary tract infection. If there is nitrite, it could mean urinary tract infection. If there is ketone, it means you are not eating well. Your body is breaking down stored fats, and we will know. So some women are surprised when I tell them, Madam Kate, you're not eating, no. How did you know? I will know. I knew because I saw ketone in your urine. So it helps to tell us how your body is doing. Okay? So it's very important. So when you are coming to the clinic, don't empty your bladder and say, you just say, oh, I just is myself. Please keep some urine. Once you come, go in there, do your vitals, give them urine. They will check the test. They will do the test and then they will have it. All right? So after you have done your vital signs, then you come in to see your doctor. So if you're coming for the first time, like I said, most of us here, you will not have the opportunity of having this proper booking done, because a lot of things, like now when we're getting to the first booking, all of these histories have already been taken before. When you came in for your first consultation, when you came in for fertility treatment, we took all of this history. So we already have your history. We already have your biodata. We already have your medical history, your gynae history, obstetric history, surgical history, medical history. So all of these are all with us. All right? But this is what is done. All of these histories are taken, and thereafter you will have your scan done. So you have your scan done. For us here, patients who register with us, they have the luxury of having scans done every time they come for their visit. So you can see your baby, you can hear your baby's heartbeat every time you come for your antenatal care. And then you go, after you are done with the doctor, you go to the lab to have your samples collected. You're starting, and these are the tests that are done. And then after, you go in and then have your medications. Now, go back to the first one. These are routine tests. Every woman going through antenatal should have this test done. For those who went through IVF with us and are doing antenatal with us, remember we have done your blood group antenatal before, and then we have done your serology test. So we have all of these details. For full blood count, we will do. All right? Next slide. Those other tests are not general to everybody. The Combs test is done for patients who are rhesus negative. Either rhesus O negative, B or A negative. Once you are a rhesus negative patient and you are pregnant, we must determine your Combs test, whether you have been sensitized or not. What that means, whether you have developed antibodies. And if that is the case, then your management will have to be known and different. All right? So if it's negative, which is good, then you must ensure that you have the ROGAM injection ticking. One while you are pregnant, 28 weeks, and the second 48 hours after you have delivered, you must have the injection to prevent sensitization. And then of course you do your fasting blood sugar in 2 hours. And there are women who are predisposed to developing diabetes in pregnancy. Patients who have previous family history, maybe their mom or dad are diabetic. All right, men who are on the big size. So usually we will do this once we pick up any sign. Remember I said every time you come for your antenatal, you must do your analysis. So the first indication that you may be having high blood sugar is your urine will become positive for glucose. Once that is picked up, the next thing you will need to do a blood test to determine whether indeed your blood sugar is high or not. And of course, the gram beep streptococcus test is done about 35, 36 weeks. Rule out infection. This actually is a compulsory test done for patients who are traveling outside the country. They will have the test done. At 28 weeks, you will have your PCV, and then you have a fasting and 2 hours done. And then at 36 weeks, you have a repeat PCV done. All right. So for patients our patients who are here, so typically what happens is that, when you are done with your luteal support, part of our protocol is that you do your cervical circlage. And when you're coming for your cervical circlage, you go in to have your full blood count done. All right? And after you are done with your cervical circlage, 1 week after, you register for your antenatal officially. Okay? And then you continue with that. And then at 28 weeks, when we are doing what we call the fetal lung maturation, we are also doing your PCV and your fasting blood sugar and 2 hours. All right? And then at 36 weeks, you are repeating your PCV. At this time, we're getting ready for your delivery. Next slide. All right, so obstetric scan during your ANC, like I said before, each visit you are obliged, you are given the benefits of having a scan done. But I'm thinking that this scan we are doing, I'm thinking we should reduce the number. Why should women be seeing their babies all this time? What? At least twice is enough. Those who are in favor of 2 times in the antenatal, say aye. So those who want to be having scan done every time they come for visit, say aye.
Let's have the scan
in the house. I understand. But you know that thing is possible. They have portable devices now that you can use to, I'm with now, that you can use to determine the heartbeat, and you can also use to even, scan your baby. So if you want us to provide that for you, why not? We will provide you with those devices. But there was this idea I mooted sometime about doing online antenatal care. I was still going to do that. And these are for patients who are not based here in Abuja. I can conveniently run your antenatal care online, trust me, and I'll provide you with good care. So it's something that we would do later on as our patients become a lot from around the world. All right, so you have your scan done. So you have your first scan. For most of us here, you usually have your first scan. You start your journey with us very early, from the very day. Why? Because we know when it will happen. So from when you got pregnant, 2 weeks after you come for your scan, you are doing your scan. The purpose of that scan is to determine viability, to check the number of babies you're carrying, the position of the babies, where they are, whether they're inside the womb or outside, the number, and how well they are doing. So any scan a woman is doing, your very first obstetric scan, that is the purpose. So typically a woman who gets pregnant spontaneously will say, oh, I missed my period. Oh, I did a pregnancy test, it is positive. Congratulations. But you are actually pregnant after you've had a scan done. But that is what determines clinical pregnancy. Because you could be chemically pregnant and there's no pregnancy in the womb, in which case it's chemical pregnancy. Or you may be pregnant and the pregnancy is not in the womb, it's outside the womb, that's ectopic pregnancy. Or you could be pregnant and the pregnancy is not doing well, in which case you're having a blighted ovum, you have a missed abortion. But when you have done your scan and you see a heartbeat, then you can confirm clinical pregnancy. So I want to say here for those who are watching or who will watch, particularly those who go through IVF and you had a pregnancy test done that says positive, congratulations, you've got times. Come for your routine scan. Each time you come to the clinic to see the doctor, you will have a scan done. They will check how baby is doing. They will measure the baby's growth parameters. Depending on the age of the pregnancy, they will know what to use. And all of this is just to determine how the baby is doing. All right? And then 16 to 20 weeks, you have an anomaly scan done. We have a 4D scan available, but all of these are all available for us, although we've not started doing the 4D scans. So don't say, doctor, people did not do 4D scan for me. We've not started that. Okay? So next slide, what is the schedule of your antenatal clinic visit? Usually 3 to 4 weeks until you are 28 weeks. All right? And then 2 weeks after 28 until 36 weeks, and 1 week until you deliver. However, for most of our patients here, we see you every 2 weeks. And the reason for this is because patients here just want to see their doctors frequently. They want to, but if you give them the chance, they say every week, I don't mind. How many of us want to be, let's make it every 4 weeks? If you are in that group, say I. Nobody. Okay, how many of us want us to continue with 2 weeks? Say I. How many of us want one week? Say I. We don't want 1 week. We don't want 1 week. So we do 2 weeks for our patients. We want to see them more frequently, just because of the nature of their conception, right? Just to give a close You know, we expect good outcome whenever it is. But you know, when a woman uses a baby during the first whatever it is, you have to say, for you after all of this, you have to maybe, for example, have fetal distress when the baby was doing was being born, and baby comes out situated, or baby comes out, maybe you're waiting for labor to start, and then you got your 30 minutes, you're still waiting. 41 weeks, you're still waiting. And 42 weeks, they were not started. But what you think of that baby has already started having distress. And then by the time you now start the labor, baby is now in more distress. Time baby comes out, baby will not have made it, baby needs it as life. So the question will be, why did you have to wait and go through all of this? So because of all of this, we just decided that it's safer just to selectively offer our patients peace of for us to them to have the ability to do that. And if we are doing that, we do that between 37 to 38 weeks. 38 weeks for those who are carrying one. 37 weeks for those who are carrying two. For those who are carrying three, yes. But usually, once you are 64 weeks and above, your baby at least has achieved maturation in terms of the lungs. So the critical thing for us, where we pray that all women breastfeed is 24 weeks and above. But in terms of premature, you have to be transgender confident. It is transgender confident that baby is 10 that you can have. All right. So once you get to 26 weeks, you begin to make preparations, you make your deposits, you get a list of the nurses, of things to buy for yourself and for the baby. You need to prepare, you should have done by this time, you should be done with your shop. Not at least I say you now carry your people there and you say nothing. You say you want to go and buy the no. By 36 weeks, you should have finished your shopping. You should have arranged the clothes, arranged your box, and you lock it. What's going to be keep to the go when the time comes. All right. So you get all of the necessary things. At 36 weeks, you also will get to the lab so that you can collect your blood and do your all the tests, make blood available for you, and get you ready. So some people, because you are going to believe naturally, probably try and give you some exercises, all right, just to get ready, and thereafter the video comes, you are delivered. All right. Patients who deliver through cesarean section use of pillows end between 3 to 5 days. All right. Majority 3 days. By 3 days, they're good. Babies are fine. Are heading home. Within that period, the baby should have had immunization, the first set of immunizations, then go to see us after 2 weeks, and then after 6 weeks. After 6 weeks, if there are no issues, after 2 weeks, if there is some issues, maybe like having the blood pressure was high, and we need to just see you within a short time, and we'll give you a 2 weeks appointment, and then you will come. All right. And then when you come for your postnatal care, we will check both you and your baby. The baby sees the pediatrician, and then you see the pediatrician, and then we check your vital signs, sure that all is well. All right. We ask about feeding. We expect that all our mothers will do exclusive, except of course those who are carrying more than one. If you are carrying more than one, you can't do exclusive. Never. You just want to just kill yourself. The stress will be too much. So we expect that we'll find out how you're doing, but you should do more than 60% breastfeeding. All right? And then ensure that you're doing your immunization. And Then we discuss contraception. For women who got pregnant through IVF, we don't discuss contraception. What are you contracepting for? Drop this one and come again for the next one. But you're even eager. I say, when am I coming again? Contraception what? For what? All right. And then we have our antenatal classes, okay, like what we are having right now. So those are the things that constitute the antenatal care that we offer. The other things here are the cost for our antenatal services. To say that these costs they are subject to change without any reference to the patient. But right, I think right now that okay, next slide, that cost is still what is there. If you're doing an antenatal with us, the package is 250 only, and then oh yes, only. And these are the things that are included in the package. All right. Next slide. All right. So these are all the costs for our delivery packages. Okay. Next slide. Next slide. Next slide. Next slide. Thank you very much. Okay. So thank you very much. Questions? Any question? No, sit down. Sit down. Sit down. Hmm. Who asked you? Okay. Okay, the pharmacy. No. So how are you feeling now? So if you're having that, the more likely is a fever and malaria. So you need to, yes, that paracetamol was a rare prescription, but I think you need to do tests just to be sure that there's no malaria parasite. And if there is, then you have to repeat it. Okay? Yes, yes, yes. Fine. You can go for the vital signs. Mm-hmm. When you say activity, what do you mean? Because you know, sedentary life for a woman that is pregnant is not good. Meaning that you don't do anything, just stay in one place. No. But you can move around, go to kitchen, go to bedroom, go out. You can, yes, you can drive. Yes, you can drive. Why can't you drive? Yes, so if so if because of those kind of logistics, road is rough and you don't have the kind of mobility that will help you to move around, so you can. Road is bad. You go slowly now. Yes, she no, you're all VIP, so she's actually practicing the VIP very well. She's trying to be careful. Yes, yes, yes. See, um, no, you can, you can. You just make sure that you're not stressing yourself. You understand? Just make sure. And again, the other thing is that all pregnancies are not the same. That's what I must tell you. So you need to also watch yourself. Don't say, oh, see, can't you see this one? He's jumping up and down. Bodies are not the same. And so you need to be able to watch and see how you're doing that way. But Staying in one place and not moving around you need to have you need to move around. Yes. Hmm? Yes. 37 weeks. The fear of incubator. Yeah, but it depends. It depends. Sometimes baby born at 36 weeks cannot get into incubator. Baby born at 35. So it all depends. Some babies born at 37 weeks can get into incubator. Oh yes. So it's only when the baby is born. But most of them will not get into incubator. But most preterm will get into incubator, depending on the age at which they are born. For babies born before 34 weeks, definitely get into incubator because they require respiratory support. Yes, 34 weeks is the threshold. So babies born at 34 weeks, some may not. So it depends. What we use is not the weight per se. What we use is the age of the baby. Because if the baby is born at say 32 weeks, even if the baby is weighing 2.5, that baby's respiratory lungs will not be natural. That baby has to be in the incubator. So we don't use weight. But because most premature babies are born with lower birth weight, there is a weight that baby has to get to before the baby is discharged from the incubator. And that weight is between 1.8 to 2 kg. 8 to 2 kg. For babies that are born beyond 2 kg that have to go into the neonatal, it's some weight that is they are not waiting for. Once the baby is fine, then the baby can be discharged. Some of those discharges are normal, some are not normal. Because of the hormones, some women will have increased, there's a general increased discharge. Yes, so general increased discharge. Ciclovina, yes, there's a general increased discharge. But sometimes that discharge may become abnormal if it's becoming very excessive. And if there's a smell, then you need to complain to your doctor so that they can do a test. It depends. Some women will have it, some may not have it. It may go and then it may come back. Okay? Mm-hmm. Twice. Twice. Once you are above 16 weeks, you have the first shot, and after 4 to 6 weeks, you have the second shot. Have you completed the course of 5 before? Because there are some women who probably before now had done a normal full course of 5 doses. So for those ones, all they need is just a booster dose when they're pregnant. Well, if you have not done that, then you need to have two doses, right? And if you've had one, then you have the next one. And December. So are you close to delivery? As in very close, like 1 week or 2 weeks? Okay, so you want to you should check and find out how many weeks you are. If are you less than 36 weeks? And then you can have, and when you took the first one, it's more than 4 weeks, and you can have the second one. So those prices have changed, right? Those prices were prices when we prepared, when don't look at those prices. This slide was prepared like 2 years ago, so prices have changed. Don't use those prices. Meet accounts. You don't have to see water to undergo labor. For the question you're asking, can you see water even with a circlage? Yes, you can. Because you can have the water rupture even with a circlage. Maybe there's an infection. All right. Once that happens and you're not close to delivery, then that circlage will have to be removed. And then depending on the age at which it happens, if it's very far from viability, when the baby will be fine, then we need to monitor you conservatively and see how we can push the pregnancy to as far as possible. If all the water have leaked out, management now depends on your age at which it happens. If it happened before the age of viability, in which the baby is not anywhere close to making it, if you are delivered, then we treat it as an abortion, and we just try to give you, um, we evacuate the uterus. But if it happens after 28 weeks, like I said before, we will try and tarry. If you've not done a fetal lung maturation, we would do that just to hasten the maturation of the baby's lungs, and then we will effect the delivery. Baby will be not in the neonatal intensive care and hope for the best. Not necessary. Not necessary. Okay. When do you eat? In the night. Is it because of the drug you are eating that late? You don't have to. What drug are you taking? Your routine drugs. You don't have to eat that late to take your routine drugs. Because typically, women, when they are pregnant, they have this feeling of there's something hanging there, yes. And it's typically worse when you eat late. So eat early. And moreover, why are you waiting to take your drug by 9 o'clock? Why not take it earlier, by 6? That's 6 to that's 6 to yes, you can take without food. And then you don't have to wait till 10 o'clock. It's TDS. It's not the reason why they give those times is so that people can follow instruction. But if you are an early to bed, you don't say, these people, because they are punishing me. I have to wait now till 10 o'clock. You can take it by 8 o'clock. No problem. Hmm? No problem. And this really started after the procedure. So you need to check your blood pressure. Okay, your blood pressure is fine. That is 120/75. That's fine. So yeah, so it just was very low. Okay, you're welcome. So it depends on. So it's just to watch it. Are you taking a lot of fluid? How many liters? 10 of that bottle? Hmm. You are doing well. Yeah, because if you are dehydrated, you can have headache. So it's just to make sure, yeah, so we just monitor your blood pressure. And then um, you also had, was this spinal you had? Spinal, right? Although these days we don't get headache from spinal because of the needles we use. So it's just to just further observe and see what happens. Also to be sure that you're not having malaria, any fever, anything. The drugs. Mm. It stops. And then when you take it again, okay, so it's to find out what is it that you are taking. But before you did your calculate, you were taking those two drugs. Or the or is it the salbutamol? Oh, nifedipine. Oh, sorry. Nifedipine. You choose between nifedipine and salbutamol. Okay, but you can take that nifedipine once. You don't have to take it twice. So you said you take the morning and then evening again, you see, oh, the antibiotics. But I think it's the nifedipine that is causing the headache. So that causes headache. And so maybe what happened after like it's just a week now you did your checklist. So after one week you can stop. Mm. All right. So question, question for my online audience. Yes. No, 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 no. Coffee not okay, except it is decaffeinated. If it's decaffeinated, then yes. But caffeine, no, not advocated in pregnancy. Okay. Next. Don't understand. Which discount? This is antenatal class, not fertility program. In antenatal class, there's no discount. We're not offering any discounts. Okay? So maybe you need to reroute that patient to a fertility forum. I didn't mention anything about 40% discount. So that's for the fertility. Next. For a baby and a solution. So it depends on the age of the baby. Babies that are born prematurely, their heart rates are very high. All right? And then, and there are so many things that can cause the heart rate. That one is as a result of prematurity. As they get older, the heart rate begins to get stabilized. And now some babies, some newborns, or probably neonates may have high heart rate because of low blood level, PCV. So, or it could be as a result of malaria, they have fever. So once you check and the baby's heart rate is above the normal for the age, then you need to carry out the investigation. So it's something that you need to see the doctor for. All right? So you see the doctor, they will carry out investigations and know exactly why. If first of all the heart rate is normal or not, and then if it's not, then what's causing the heart rate to be high. Then based on the investigations and evaluation, they will not know what. All right? Next question. Any more questions? Okay, so you're welcome. So that we have finished with the new presentation. We're asking questions now. Sorry. What causes waist pain? Not a lot of women have waist pain. But um, waist pain that we are worried about is waist pain that is due to contraction of the uterus. If a woman is having a menstrual cramp that comes and goes in early pregnancy, if it's mild, not a problem. Just take a lot of fluids, rest, take paracetamol, and then you're fine. But if the pain is severe, you're having severe cramps and you're pregnant, then that can be a cause for worry. You need to come to the hospital. It could just be that there is a challenge, the body is trying to reject the pregnancy. And oftentimes, when you have that, it will be associated with bleeding. Okay? Associated with bleeding. If it's not associated with bleeding, then once the pain is severe, then you have to come to the hospital. You don't take chances. It could also be as a result of fever. It could be as a result of urinary tract infection. It could be as a result of pelvic infection. It could be as a result of fibroid. All right, there are many things that can give um, that that um, that waist pain. But it's to be able to differentiate it from just having a regular waist pain, which is muscular, from the pain that is coming from the uterus as a result of something. All right. Take water. Try. Eh? I know you feel like vomiting, but try. So what you can do is to mix. If it's just ordinary water that is making you vomit, you can add something to it. You can do Ribena, you can do Lucozade, you can do anything. Just change the taste and just sip it. All right, just sip. But it's good for you to be hydrated because if you don't take enough water, and when I say enough, it varies. I'm not saying you do like 10 bottles, like my patient is doing. At least, no, no, I'm not saying you should reduce. Fantastic, fantastic, fantastic. So I'm not saying you should reduce. Uh, there are people who don't like taking water, which is good. All right. But what I'm saying is at least if you know you're not, and there are people who know they're not taking water, they should improve on it because if you don't take water, it can give some other conditions. You can have headache from just not taking water, from being dehydrated. You're gonna have cramps because you're not taking water. Mm. So that you will not be dehydrated. Mm. So, so you take more. Four of this. What is the liter of this one? Huh? 3 liters, but that's 3 liters. That's okay. I mean, that's the minimum that you should take. 3 liters, so that's fine. It's just the weather, yes.
From just from 8 to 9, I'm taking like 4. Then from 9,
No, but truly, why are you taking the water? No, what's the
like,
now when you take it, it gets better, right?
yeah, like I'm not
Mm-hmm.
like,
Exactly.
so like I'm sleeping, I'm sleeping.
Because if you don't take the water, what will happen? Exactly. So take water now. No, I'm not saying it's too much. I did say it's too much. See, your body has the ability to take. If you take more, you will wee more. The only discomfort is that you go to the toilet to wee more frequently. That's all. That's all. I understand. We have people in this generation that they go with water bottle all the time. They're always taking water. It's good. All right. Any more questions? Hmm. Very important question. Uh, so after, thank you very much for that question. Because these people here, I'm sure they had that question in their mind, but nobody wanted to ask the question. All right. So after cervical circlage, you're supposed to give like another two months, 8 weeks, and then you can meet with your husband. But the experience, well, that's what I think. By the time you get to that time, that means you're about like 5 months, 6 months. Your mind is not there anymore. So, so what we are indirectly telling the men is that you zip up from the next 1 year. Yeah, it's not up to 1 year. Because if you get to 5 months, 6 months, and you say, I beg, just hold your own, you have to wait until 9 months. After you deliver 9 months, you can't just deliver and immediately now. You have to give another like 6 weeks, 2 months to heal. So add it together. So you have a question to ask in that matter. Hmm. Let her ask the question. Please go ahead. You allowed him. Okay, you did just to help him. Uh, you needed it. It's not easy. See, I understand. It's not easy. Hmm. So allow. Hmm. You see, is that see? So, mm, that is why we said we should not. You understand? Because when you achieve orgasm, all right, your body goes through some contractions that include your uterus. Also, if there is penetration and there's release of sperm, that sperm contains prostaglandins that can cause contractions. And worst of all, that if there is infection, remember you have the sacrilege, and then the sperm, the semen, now has some infection that can cause. I know. I'm just saying generally. Reason why we say no sex. All right. Not this. So it's just to exercise patience. By the time you get to like 5 months, 6 months, then why not if you're up to it and go ahead. It now depends on you now. So I said, you think it's easy to stay for 1 year without anything? Okay, the helping part. Okay, so the thing is to say is understanding. Men, I know it's not easy. But you see, what we're trying to do here is trying to be careful. Do you understand? If it was not IVF, if there was no cycling, any time of pregnancy, you meet with your wife, no challenge. But if you meet with your wife and she now starts bleeding afterwards, you will not forgive yourself. You understand? You carry that guilt. As to, what was I waiting? What was I looking for? Is it that I could not hold myself? You understand? So it's all out of an abundance of caution. You understand? Because it's possible you meet after 1 month, 2 months, and nothing will happen because every woman is different. And it's also possible that immediately after you have finished, Wahala have started. So just to avoid stories that touches the heart, you just say, just Allah help me. All right? Because we've all waited for this for too long. And now that it has happened, let's just provide all the necessary. Okay. Next question. Okay, so that's also a very important question. Is the gestational age calculated from the day of transfer or from when? Insemination. Neither of them. You start calculating. So the date we use as reference is actually your date of transfer. But by the day you are doing your transfer, that pregnancy is already 19 days. 19 days. So if you did your transfer today, for example, and then you are coming to do your pregnancy test after 2 weeks, that and you are confirmed pregnant, that pregnancy is at least 4 weeks plus. And when you are coming to do your scan after another 2 weeks, when you do your scan, that pregnancy is 6 weeks and 5 days. That's why you notice that when they measure the sac, it's reading 6 weeks plus. All right. Using the rule, the Nigelis rule that we use, you know, if you got pregnant naturally, it's not you won't know when fertilization occurs. All you know is when you saw your last period. That's what we use to calculate. So we assume that all women we use the 28 days circle rule. And you know, the embryo we transfer is already 5 days old. So you calculate 14 days to when we did the insemination and 5 days after we did the transfer. So that's 19 days. So add 19 days upward and you calculate how old the pregnancy is. All right? Next question. That's all. Okay. So I want to once again on behalf of the team thank every one of you for attending this um, month antenatal class. What we did was just take us through what antenatal is like at the center here, what to expect, so that you are also part of the process. All right, now that you have been taught, now for those of you who missed it, you can go back and watch the video on online on our site. You have the full video. Right? So I want to once again wish every one of you a very successful process. For those who are close to delivery, I wish you all the best and you will deliver safely. For those of you who are just starting the process, receive grace, continue through the process. Everything shall go well, and very shortly you will deliver. You would have successfully ended this journey that started some time ago. God bless you and have a wonderful day. Do we have something for them today? The fasting is over. But pregnant women, they don't fast too. People fast. You fast. Why? Why you fast? 21 days you fasted. Why? Don't fast though. No, Oga, I didn't say money. You should fast. You fast for your wife. Just say men should fast. But women, once you are pregnant, please. That you don't feel like but not that you not decide
covenant keeping God, I worship you today.
Next week, next month.
Covenant keeping God, you can never ever change.
Still very fast. We start by 2:30. Is that what you want? No, 12 one is
covenant keeping God,
because we have
I worship you today.
Thank you very much. Ten, 11. No, a lot of people. So, a lot of people have activities and events, things that they do. So that's why we usually pick in the afternoon. Except if we want to probably be doing the antenatal first before we do the fertility forum. It differs for different people. There are people who may want to attend one activity before coming for the antenatal. So, thank you very much. God bless you. In camera.